All right, I want you to look at this page, and I want you to tell me, what do you think is the most important things to learn about headaches? What do you think? And I'm hoping that you're kind of focusing on type, timing, and signs and symptoms, okay? Because that's what I want you to be an expert at. Now, let's start with why these three. Okay, timing, okay, is part of OPQRST. Remember, onset, cognitive provoking, sight, timing, right, or severity timing. So timing, 3 to 5 days, 1 to 2 hours, afternoon, morning, repetitive, gradual, progressive. See, timing is pretty unique to each one. Timing is the best piece of information to start to tease apart headaches. And this is the wrong way to do it. What time of day do you notice the headaches? Because you're not asking if they're episodic, if they're recurrent, if we have them over and over, if they're associated with any activity beforehand. So timing is, oh, right after okay, or only in the fall, or see, now we're finding out they're allergic. So I want you to really understand that with timing, you've got to ask 3 or 4 timing questions. Is there something that brings them on? Do they notice that something occurs when they have them, during the time that they have them, or just precede it? Okay, so you see how that's all related to timing? Does that happen and then this happens, or does it happen at the end of the day? Or so that's the kind of thing I want you to get really good at, timing. The next thing is the signs and symptoms. So is there a certain food that aggravates it, a time of year that aggravates it? Do they hear ringing in their ears? Are there any other things that kind of accompany it? Is there sinus involved or congestion? All right, now over here, the type is where you get your third answer. So maybe you know it's migraine, and you pick migraine, and you pick classic migraine, and now what do you pick? Well, it's a vascular headache. Okay, so I want you to realize then that this type over here gets you your second and third answers quite frequently. So make sure you take the time to do that because, for example, I'll show you just a tricky one. If you can see giant cell down here, giant cell is a headache with a fever. Okay, you see it's one of the 3 with a fever, but it is not an infectious headache. It's autoimmune. It's inflammation. Okay, so it's a little bit tricky. It's vascular and autoimmune. So that's why I want you to take the time to do this. Okay, so let's just run through here and talk about a few tricky things because by now you should be pretty good at headaches because you are absolutely going to have a case history on headaches. Okay, or if they don't do a case history on a headache, they'll probably put a headache in your orthoneuro room, in the cervical room, and see if you can kind of figure it out with some orthoneuro testing. Now, when you look at this, I want you to understand that migraines are episodic. No, it's very rare to say, I had 1 migraine in my whole life. That's kind of a rare thing. So usually they're episodic, and that's important to understand. Aura is what accompanies a classic, so it's important that you ask if there's that sensation that precedes it if you think you're dealing with the migraine family. Cluster headache, and you can adjust them. I hope you understand over here, and ice is what we start with. So hopefully by now you're kind of, that's a duplicate. I've already said that information. Cluster, if you'll notice, I don't talk much about sight, except for cluster and sinus, because cluster is a runny nose, runny eye, and just one side of the face, versus sinuses bounce around back and forth, feeling congested. It's the whole face. So cluster is an allergic-based headache, usually seasonal, okay, and natural antihistamines will help these people, so we want to adjust and get some antihistamines in them, preferably the natural variety, but that needs to be done. And these only last about an hour, and they're really nasty, piercing headaches. So we want to be able to parse that out from sinus problems. Then there's the tension and cervicogenic family. Now tension, stress, muscular, usually just all in the head. If they start saying words like cervicogenic or vertebrogenic, there'll be some pain into the shoulders and arms because it's associated with radiculopathy. But these are our headaches. We take care of these. Actually, we made up the ICD code as chiropractors. So band-like spasm, muscular headache, we want to put heat on those just like we would torticollis. It's a spasm. Now, hypertension is a metabolic headache, so I just kind of parsed it out because I wanted to use it as an example of a vascular one because we have enough patients with hypertension, with diabetes, arterial sclerosis, atherosclerosis, that I wanted you realizing that they're going to feel worse in the morning because we're supposed to repair and recuperate at night, and their blood products just are too thick and heavy and don't do that. They wake up gooier. So, I want you to think of the metabolic headache that most of you know about, which is a hangover. And so the night before you feel great, but the morning of you're toxic, you don't feel good, okay? And as you drink and pee, Okay, whether it's hypertension or metabolic headaches in general, when you drink and pee, you get a little less toxic, you feel a little better. By the end of the day, you're pretty good. But then you go back to sleep, you build up the toxins, and you wake up toxic once again. So, do we take care of these? Well, usually we're co-managing these because probably somebody's going to have to find out what is the root cause of it, how bad is it, does it need to be, medicated as well as adjusting. We try to keep the meds down by adjusting them better and giving them good habits to improve whatever's going wrong. Now, sinuses above and below, we want to do that, waters or some sinus x-rays if necessary to see what's filled with fluid. We want to maybe do the jar test. If you want to hurt them, they drop down and lights up their sinuses. We can take care of them, but if they're not improving, remember that sinus headaches are close enough to the brain and ears and other parts of their body that they'll probably need some medications. Clean it all out, then maybe we can start working on prevention and neti pots or other things that you know of to keep the bacteria count down and in check and keep those sinuses clear. Now, giant cell is one I brought up earlier. It has a really high SED rate, so I'm sure it's up here. Yeah, an elevated SED rate over 80 and somebody over 50. Now, I put somebody over 60 here. What I want you really thinking is aging patients. So if they're 58, don't parse with them. But I want the older patient. It's not going to be a 21-year-old. It is an autoimmune attack on the vessels, and they can get achy all over, but man, if it happens right here, it's dangerous, and they could lose their vision. So that's why we always point out that we're going to refer even though we're adjusting. So it's okay to adjust, but you've got to refer to the ophthalmologist so that they can be addressing this with corticosteroids and get that calmed down, because they need a few months of that just to calm this area down so they don't go blind. And I take 2 months of corticosteroids if it would mean I wouldn't go blind. I don't know about you, but I would do that. All right, now tumor, intracranial, space occupying, stroke, that's the language that we usually give to that category. Now a tumor is going to come out probably pretty slowly, as opposed to a stroke usually comes on pretty quickly. FAST, fast, is our mnemonic for stroke. So tumor kind of slow, they're not quite acting right, they get a little fussy, they're not getting along with folks, personality changing. At night they kind of feel weird, and now the pain's keeping them up. So we talk about it in kind of 2 basic words: progressive and a nocturnal awareness, and eventually nocturnal pain. So those 2 words kind of give it away. The personality changes might give it away, and of course this one is a referral out. The meningeal headache is going to hurt with the flexion. They're going to be running the fever. So it's one of our 3 with fever, and this is definitely infectious headache and 1 episode. I don't want meningitis twice. It's not worse in the morning. You have meningitis the whole time you have it. So we know to refer that, and it's going to be confirmed by the CSF puncture or spinal tap. Now this next one I want to draw you a picture for, so we'll have to pause for a second.